to this AIOS Masterclass today. And we have an AIOS Masterclass today by none other than Dr. Praveen Krishna Vadavali, who's going to be talking about, I think, his most favorite topic and our most favorite topic, and that is endothelial keratoplasty. Of course, he doesn't need any introduction. He's known to everybody, and he's been doing these courses on various aspects of lamellar keratoplasty, which are really doing very well, both nationally and internationally. Dr. Praveen Krishna is the Network Director, Technology and Communications, and is also the Director of the Cornea Institute and Institute of Excellence at LVPI. He's an active member of American Academy of Ophthalmology, the ASCRS, the International Society of Refractive Surgeons, Cornea Society, and the AIOS. He's also the founder and executive committee member of Cornea Society of India, and was founding scientific committee chairman of the Telangana Ophthalmology Society. Currently, he's also the secretary of the Cornea Society of India. He has a keen interest in technology and applications in medical science, and hopes this blend will lead to delivery of equitable and excellent eye and healthcare in the future. He has devised innovative modifications in lamellar keratoplasty and is involved in the research projects in the field of keratoconus, lamellar keratoplasty, and refractive surgery. An alumnus of Bangalore Medical College, he did his master's in ophthalmology from Guntur Medical College in Andhra Pradesh, and later did a fellowship in cornea and anterior segment at LB Prasad Eye Institute, Hyderabad, and subsequently joined the institute in 2004. And eventually, he also did a one-year fellowship in cornea and refractive surgery at the prestigious Baskin Palmer Eye Institute, Miami, USA. He is the recipient of the several national and international awards, including the Young Investigators Award for the Outstanding Research in Clinical Ophthalmology by ARVO, the Best Paper in Cornea by AIOS, and several other best papers and awards by the American Academy of Ophthalmology and ASCRS. He serves as a reviewer for numerous international journals and has over 110 peer-reviewed publications and over 700 national and international presentations to his credit. And on the lighter note, he loves to read, travel, try new cuisines, play sports, but is happiest when seeing patients in the clinic. So Dr. Praveen Krishna would be talking about endothelial keratoplasty. So over to Praveen for his masterclass on endothelial keratoplasty, and who could it be but the master blaster himself, Dr. Praveen Vadavali.
Thank you so much. I mean, Namrata, that is quite embarrassing, but really, given that both of you are such accomplished keratoplasty as well as endothelial keratoplasty surgeons, I mean, what you just said, it means a lot coming from both of you. So thank you very much for the opportunity to speak on this forum about endothelial keratoplasty. And like Dr. Namrata Sharma said, it is something that is very close to my heart for several reasons. One of the reasons is the fact that I went through my own struggles to learn it. And I think that is what actually makes you a surgeon who understands that the learning curve also has a lot of difficulties. And I think the goal is to shorten the learning curve for most of those of you who are listening today. So since today is a masterclass, and what we will do is we won't keep it extremely long. I think hopefully it'll be a little bit interactive as well. So what I will do is I will speak a little bit about the endothelial keratoplasty, evolution of keratoplasty first. Then we'll talk a little bit about the types of endothelial keratoplasty, the different surgical techniques, and we'll end with potentially what we can look forward to in the future. So very quickly, just for all the residents who are potentially listening in, this is something that I found very interesting. And it's nice to know about how keratoplasty really evolved. This is more for the history buffs among you, and for those of you who like to participate in quizzes as well. The concept of keratoplasty actually happened very, very early, almost 2000 years ago. But the first keratoplasty was actually a glass keratoprosthesis that was first transplanted in the 17th century. Following this, the experiments were mostly in animals, where transplants were done in pigs as well as gazelles, of all things, in the 18th century. And it's only in later on that xenograft was tried And the actual first human transplant was in 1900, about a little more than 100 years ago. So the first eye bank actually is also short-lived, only about 70 years ago in New York. And after that, modern keratoplasty, probably one of the fathers of modern keratoplasty is Ramon Castavio. In 1965 is when he did his first square keratoplasty in some patients, and some patients still do have clear grafts. Following that, we had several evolutions like anterior lamellar keratoplasty, DALK in the 70s, and more recently, endothelial keratoplasty, DSEK, followed by DMEK. Again, probably credit Dr. Gerrit Meles from Rotterdam, Netherlands, for this evolution. So very quickly, also going back to see how we are doing as a country in India from the point of view of corneal transplantation and tissues. And if you look at this map, all the red areas are countries that are that have almost no corneal transplants going on. The blue countries are the ones that have surplus corneal tissue, and the green ones are the ones that actually have just about enough corneal tissue. And you will see that India actually is in green, almost sufficient. And I think all of us should feel proud about it. And I think also we should be grateful to some of the members of Indian cornea for the last several years, including whom you see Dr. Namrata Sharma as well as Rajesh Sinha, for achieving what we have achieved so far over the last several decades. Now, the other interesting thing that we also should take note of is the fact that in India, we have about 10 times as many eye banks as in the US, though we do collect fewer tissues than the US. But then what is also interesting to note is with the increase in transplantation, and this is something for all the young residents to note, that 55% of all the transplants in the world in 2015 were done in 3 countries, US, India, and Brazil. And I think India did contribute a significant number, about 25,000 of those. So again, no mean feat, and something that we all have to feel proud about. But the worry comes when we also look at the burden of blindness that we still have. And if you look at this inflated map on the right side, where the countries that expanded to depict the amount of burden of blindness, you see that India actually has an unnaturally high percentage of patients who need corneal transplants. So it's not the fact that we are doing enough, we have enough tissue and we're doing great already, but 75% of all people who are blind in the world actually are in the developing countries, which accounts for only about 60% of the world's population. And if you're looking at the reasons why we do transplant in our countries, especially in India, the most common indication is still a corneal scar, but infections, keratoconus, and failed grafts are also very significant indications for doing keratoplasties. Keratoplasty has very good outcomes in some diseases like keratoconus, but penetrating keratoplasty has not had fantastic outcomes in corneal edema or pseudophakic bullous keratopathy. And you'll see that the 3-year survival in patients who have pseudophakic bullous keratopathy is only about 50%. That is, only 50% of the grafts that we do potentially survive for 3 years after we do the transplants, penetrating transplants in patients who have endothelial disorders. So what are the different types of keratoplasty that we are all used to? All these 2 letters and 4-letter and 3-letter words that we are inundated with, to quite simply classify them, full thickness penetrating keratoplasty, and any partial thickness keratoplasty is called a lamellar keratoplasty. Amongst the lamellar, you can have an anterior lamellar, which is ALK or DLK, and then an endothelial keratoplasty, which is classified as EK. Then you have patch grafts, limbal stem cell transplants, and also a therapeutic keratoplasty as well. So when we look back at the data of transplants at LVP, we found that from about 2007, when we started endothelial keratoplasty, the numbers or the proportion of endothelial keratoplasty that we do, which is depicted by the blue numbers here, is significantly increasing over the years. And when we also looked at the data of all the transplants that we did here over the last 30 years, about 25,000 surgeries, a quarter of those are because of endothelial transplants. So it is a significant number of the transplants that we do. And amongst the indications that we do these, about 60% of them are for endothelial disorders, and Fuchs is only about 5%. Congenital corneal disorders like CHED is a very small percentage, and about 21% is because of failed grafts. You see infections here because infection means therapeutic keratoplasty and then followed by an endothelial keratoplasty. Most common age that we have patients that we do DSEK or endothelial keratoplasty is in between 50 and 70 years, as you would expect. Most of these are post-op corneal edema patients. So let's again briefly understand what the different terminologies in endothelial keratoplasty really mean. This is an OCT of a cornea with a DSEK graft that has been done for it. And so when you do a transplant of the donor, that is the donor cornea, and you transplant some part of the endothelium and descemet's complex along with the stroma, it's called a DSEK. Whereas you transplant only the descemet membrane and the endothelium cells, it is called DMEK surgery. Anything that in the host bed, mostly in both DSEK as well as DMEK, we work by removing only the descemet and endothelial cell complex. We don't remove any part of the tissue or the stroma in both DSEK as well as in DMEK surgery. Now, what are the older types of endothelial keratoplasty that were first thought of? In fact, endothelial keratoplasty is not new, and this is the first endothelial keratoplasty that we did in LVP. This is way back in 2004, where we did a LASIK flap followed by a trephination of the posterior part of the cornea, and then transplanted the posterior lamellar part of the cornea by doing a laser ablation of the front. And then after this was done, then we put the flap back. And this was potentially the first endothelial keratoplasty we did. But then again, this had its own problems because you still had sutures. And once sutures got loose, accessing them was becoming very difficult. So we only ever did, I think, about 6 cases. And after that, this was not pursued. The first modern type of endothelial keratoplasty was the one that was done by Gerrit Melles, where he did something called DLEK, or deep lamellar endothelial keratoplasty, where he cut out a button of the stroma from the host and inserted a similar button from the back and then sutured the cornea. And this had quite some success in the early cases before it was replaced by DSEK. DLEK started in 2004 and DSEK only started in 2006 and 7. So what are the indications for doing endothelial keratoplasty? Well, looks like for us, at least, the most common indication is pseudophakic corneal edema or endothelial decompensation because of any other reason. Then we have failed grafts and Fuchs dystrophy and also ICE syndrome. There are several other rarer indications like DM detachment, STAS, trauma, bee stings, but these are extremely rare. And when we looked at the proportion of endothelial keratoplasties we do for different disorders across the years, at least up to 2011, close to 50% of all the endothelial keratoplasties that we do is for pseudophakic corneal edema. About 18% is for failed grafts, and the next most common is for Fuchs dystrophy at about 10%. ICE syndrome, as you can see, is quite rare at only about 1.7%. The lower graph, you'll also see that the proportion between EK versus PK compared to 2007, where you used to do more than double the number of PKs compared to EK, the trend has changed in 2011 also, where we do more than twice the number of EKs compared to PK for patients who have pseudophakic corneal edema. And we also looked at what kind of conditions undergo DSEK and what kind of conditions undergo DMEK. Again, we found that PBK following cataract surgery was the more common indication for DSEK, and so was failed graft. Whereas endothelial dystrophy like Fuchs dystrophy, we did a lot more DMEK as compared to DSEK in these patients. So very briefly, in about 2 slides, I'd like to also share with you, remind you about the anatomy of the posterior cornea. When we speak about the posterior cornea and the Descemet's membrane endothelial complex, we have to remember that the DOAS or the pre-Descemet's layer is also in the vicinity. And for those of us who also don't need reminding, the DOAS layer is attached actually to the Descemet's membrane by a potential space, and the DOAS layer continues as a corneal stroma. And very quickly to demonstrate what we mean by this, this is an OCT of a bubble that was achieved during DALK surgery. And this bubble actually is held in between the DOAS layer in front and the Descemet's membrane in the back. This isn't dark, but just again to show you the difference in these two very distinct membranes, and also to show you that when you puncture this bubble, you will see that the Descemet's membrane actually comes forward, bounces forward as you see, still a small bubble. So what you see in front is Dua's layer. What you see at the back is Descemet's membrane. In DSEK, we transplant the Dua's layer along with stroma and the Descemet's membrane. In DMEK, we transplant only the Descemet's membrane. In PDEK, you transplant the Dua's plus the Descemet's membrane. So that's the difference between the three kinds of surgeries. Again, looking at the ultrastructure of the Descemet's membrane, only relevant from the point of view of what we transplant. Typically, older patients tend to have a thicker Descemet's membrane, so it becomes easier to handle, whereas younger patients tend to have a thinner Descemet's membrane, so it becomes a little more difficult to handle. So let's start with DSEK surgery and what are the different steps in DSEK surgery from the perspective of getting a good surgical outcome. The first step is donor preparation. We'll go through each of these in detail. The next step is stripping or removal of the host Descemet's membrane. The third step is to insert the donor inside the anterior chamber. And the fourth step is to ensure that the donor is attached well to the back of the host cornea. So when you talk about donor preparation, there are three main techniques of preparing donor tissues. The first one is the manual preparation method. The second one is using a microkeratome. And the third is using the femtosecond laser. The most common method of preparation for DSEK is still the manual method, where you use an artificial anterior chamber and dissectors that are used to actually create a plane between the anterior stroma and the posterior stroma. So again, a brief video showing how this is done. What is done here is there is an initial cut that is made at the limbus using a guarded knife, in this case, a 300 micron knife. And after the guarded knife makes that incision, then we use dissectors to go and separate the cornea, or dissect the cornea into an anterior plane and a posterior plane. Here you'll see a dissector being inserted, and I'm showing you this method from the outside as an external camera because it's easier to see the movement of the hands and what actually happens here. And as you can see, the dissector passes into the stroma or the lamellae of the cornea, and we are actually creating a track. And once we get into the track, then we dissect sideways, as you can see here, dissecting towards where I'm sitting towards my left side. And then after that, the dissection will be done towards the right side. So this is all in real time and is not really edited, just to show you that this surgery is actually very straightforward and can be done without too much difficulty. So the next thing that we also do is to take a slightly longer dissector and then insert it inside that same plane that we've created and complete the dissection. You see, this is more curved and a little longer. And so we complete the dissection using these dissectors to make sure that we have a complete separation between the anterior and the posterior planes. As you can see, this second dissector is being used to actually separate the two. Once you separate the two, it's just a question of punching the cornea and taking only the posterior layer and inserting inside the eye. So that is how manual dissection is done. The automated dissection, also called DSEK, is again something that is widely practiced mainly in US and Europe. And here again, in several large eye banks, we have the microkeratome that is used to create this kind of lamellae, where you make a clean incision or a dissection of the cap of the cornea, and then you leave behind the posterior stroma. And then again, you punch and insert only the posterior stroma. The difference between a manual dissection and an automated dissection generally is the fact that the manual dissection tissues tend to become a little more irregular and a little thicker as compared to what you get with automated dissection. And you also have now instruments that are available to create something called ultra-thin DSEK, where you get extremely thin grafts, about 50 to 70 microns, that you can place inside the eye. And the outcomes rival that of DMEK as well. So between automated and manual, there is not much to choose from the point of view of the outcomes. The advantage of manual is the fact that it is quick, it's relatively inexpensive. Automated is a little more expensive because of the investment in the microkeratome. But it seems that the predictability of the depth and the uniformity gives you better outcomes from the point of view of refractive errors. The third method of dissecting tissues is using the femtosecond laser. Here you see the femtosecond laser used to dissect tissues, but several publications have also noted that the deeper you try to make a femtosecond laser incision, the more irregular your cut becomes. And typically patients have had poor outcomes and poor visual acuities when you try to use a femtosecond laser to create a DSEK lenticule. Now, the second step of DSEK surgery is coring the desmase, that is removing the desmase membrane from the host bed. And as you can see here, what we're trying to do in a case of Fuchs dystrophy is I've marked an 8 millimeter area and trying to remove the desmase membrane after making a cut all around and ensuring that there is no desmase left. Several investigators have also reported non-stripping DSEK surgery where you don't need to strip the desmase membrane, which is perfectly fine. But sometimes if you have a thick desmase or if you have pigments on the desmase or some amount of opacification, it's better to remove the desmase than not to remove the desmase. So it's also found that there might be slightly better adhesion when you remove the desmase membrane before you put your graft in. An example of that is, say, for example, in this case, this is a patient who had severe inflammation after their initial cataract surgery. And because of that, they developed a retrocorneal membrane. And here, what you see me removing actually is a retrocorneal membrane along with the desmase membrane, which is extremely thick and gives you very good visibility after you remove it. So in addition to the desmase, sometimes you might have to remove these retrocorneal membranes as well. The step after that, in case cataract surgery is being done, cataract surgery is pretty straightforward. The only thing that we do a little differently is to make a slightly smaller sized rhexis so that the air bubble does not go behind the lens once you implant the lens. And the rest of cataract surgery is pretty much the same, except for the fact that you wouldn't want to use a dispersive viscoelastic. You only will want to use a cohesive viscoelastic. And the other important aspect here is if you're doing endothelial keratoplasty with cataract surgery, or you have a lens in the eye, always use a hydrophobic IOL, because hydrophobic IOLs generally tend to remain clear for a longer period with the surgical manipulations and the air that is injected inside the eye as compared to hydrophilic lenses. As you can see here, this is a patient who had DSEK surgery. And after the DSEK surgery, you see there is an area of opacification that you see on the IOL. This is actually on the IOL, as you can see here. And this is because of the air bubble that is left behind inside the eye. And when you do that for patients with hydrophilic IOLs, some of these lenses tend to become calcified. And because of that, you'll have these opacities. And the only way out is to go back in and exchange that lens, which will again damage your DSEK grafts. So that is a scenario you don't want to have. So if there's a hydrophilic lens, you should exchange it. And if there is a choice of what kind of lens you put in, either put in a PMMA lens or put in a hydrophobic lens if you're using a foldable IOL. Now, this is again a cut section of the same lens showing you that the calcification that occurs in the surface is what actually causes these problems. The next step after DSEK surgery is inserting the donor. And this is, again, can be done in many ways. The earliest way in which we used to insert donors is to fold the graft and then insert it inside the anterior chamber like a taco or a chapati or a roti, as we would normally call it. And once you do that, then you use an air bubble to open up the graft so that it is adherent with the stromal side up and also is completely opened up by the air bubble. But the problem with this kind of insertion technique was the fact that, as you see in this picture, all the black areas on the left side represents areas of endothelial cell loss when you fold a tissue. And because of that, there was almost a 30 to 35% cell loss at surgical technique itself. And so several surgeons converted to something called a glide insertion, which had much lesser endothelial cell loss as compared to the previous one that you saw. So the default technique for most beginning surgeons now is the sheets glide technique. As you can see, this is a patient who's had the cataract surgery followed by the removal of the desmase. What we're doing is putting a sheets glide inside the anterior chamber, then separating the dissected anterior lamella from the posterior lamella. You see the posterior lamella is still stuck onto the endothelial, onto the sheets glide, and then we are inserting this inside the eye using a 26-gauge needle. Very simple, very elegant, and also very safe kind of technique, because this also reduces the chances of having any complications. So that is one method to insert the graft inside the eye and put an air bubble. There are several other methods like pulling the donor through, as you see in this slightly older video, where you can use a capsulorhexis forceps and pull it over a sheets glide. This is in a case this is in a pediatric patient who has shallow anterior chambers. So we're trying to do this pull through technique. The more modern technique that is used nowadays is something called the Busin glide, where you take the lamella, the anterior as well as the posterior lamella onto the glide, and then you separate the posterior lamella, that is the endothelial graft, from the anterior one, remove the anterior graft off. Remember, this is endothelial side up. And once you pull it into the loading bay or the loading dock, it is now ready for insertion inside the eye. So you see that this is not being folded like with the taco. It is only being pulled inside, and after that, the tissue is gripped with a forceps, as I will show you here, and then it is pulled inside the eye. And this technique is important. As you can see, this is a phakic eye where we're not doing the cataract surgery. We're just holding the tissue and using this is a maculoso glide or similar to the Busin glide, and pulling the tissue inside the eye so that no part of the endothelium actually touches any part of the anterior chamber. And you have very good outcomes when you use an anterior chamber maintainer along with this technique as well. Once that is done, then the next step is to inject an air bubble inside the anterior chamber to ensure that the graft is adherent, and you also ensure that there are no fluid pockets in between the graft and the host stroma. But the problem with the air bubble is the next day, sometimes patients have pupillary block. If you leave an air bubble that is very large, and so people tend to have this kind of issue. And though this can be released quite easily, it does lead to sometimes endothelial cell loss because of iris adhesions and also severely raised IOP. So we actually found out that the most common early post-op complication after DSEK is graft dislocation. So you need to leave an air bubble. And so because of that, we were trying to find out what is the optimal size of the air bubble that you leave inside the eye. And we did experimental study in the laboratory to find out what is the optimal pressure and the size of the bubble that we leave inside the eye. And in this experiment where we used an OCT to image the gaps between the donor and the host, we found out several important things. One is you don't need to have an extremely high IOP. IOP of about 30 is good enough. You don't need a 60 millimeter IOP inside the eye. And also, it would be advantageous to do venting incisions. And then we sort of also found out that extrapolating all this, the high pressure with an air bubble may not be required. You don't need extremely high pressure inside the anterior chamber. There can be initial high pressure followed by an air bubble with a normal IOP. So you don't have risk of IOP increase. But it's important to retain an air bubble in the anterior chamber and not remove all the air to enhance adhesion of the graft. Massaging the graft did not seem to have any role in improving attachments, and venting incisions may be required in some indications like in aphics or in patients who had post-keratoplasty. So once you have your air bubble in, what we do is we wait for 10 minutes and then we reduce the size of the air bubble so that we don't risk a pupillary block. You can obviously do an inferior PI to reduce the risk even further. But it seems that if you reduce the size of the air bubble to about the size of the graft, this itself will be sufficient to prevent a pupillary block and also to ensure better adherence of your graft. So in a DSEK patient, typically post-op day 1, you will see about 1/3 chamber air bubble, and this is more than adequate to ensure that your graft remains attached. So this is about 1 month post-op, showing you that the outcomes after DSEK also are exceptionally good. Now, beyond normal patients who have Fuchs dystrophy or PBK, DSEK also seems to be very useful in some situations. Like you see, this is a patient with very severe keratoconus and PMCD, and you can see the OCT shows that he has a very ectatic corneal graft. And we all know that when you do a very large transplant, as we did in this patient, they tend to reject and fail quite early, like this happened in 6 months. But the advantage of DSEK is the fact that even after failure, you can do a smaller DSEK graft, and these patients do really well. This is 6 months post-op, and this patient continues to do well, even on the OCT, several years after the initial surgery as well. So what is also important in DSEK surgery is practice. So when the Australian graft registry looked at the probability of graft survival in patients who've done less than 100 keratoplasties versus those who've done more than 100, they found that the ones who had done more than 100 had a much better graft survival as compared to those who are beginning. So it does take some time to become a good EK surgeon as well. But also the big advantages of endothelial keratoplasty over penetrating keratoplasty is in this area. And you'll see that in about 2 years, endothelial keratoplasty survival rates, endothelial cell keratoplasty cell density remains more stable as compared to penetrating keratoplasty. And also the number of grafts that fail after DSEK is much lesser as compared to those who fail after penetrating keratoplasty. So that's the advantage of doing DSEK over penetrating keratoplasty. Now, what about the more recent version of endothelial keratoplasty? And this is DMEK. So here is an animation showing you how DMEK surgery is done, and then we'll go into the surgical technique. So DMEK surgery is again done with slightly smaller incisions as compared to DSEK surgery. So you see that is the main incision that we make, and then a couple of side ports on either side so that you can access the anterior chamber. Once this is done, then again, we put in an air bubble inside the anterior chamber, and we use the scorer or the stripper to go in, the reverse Sinski, to go in and remove the Descemet's membrane and endothelial cell complex from the posterior stroma. This is an essential step in DMEK, though in DSEK it is optional, and it is very important not to have overlap. And once that is removed from the anterior chamber, then you can actually prepare your donor and insert it inside. So this is the step where we are using a scorer to remove the strip Descemet's membrane from the back of the cornea. And again, like I reiterated, this needs to be in a larger diameter as compared to what we do with DMEK surgery. So once this part is done, then the next part is preparing the donor scroll. And as you can see here, this is a donor scroll floating in fluid. We load this into a glass tube and then inject it inside the anterior chamber. And this is when the fun part starts, where you need to utilize different maneuvers to open up the scroll. So you see, we're just tapping on the cornea to move the DMEK scroll around, and then also inserting an air bubble to help open it up so that it is completely opened up inside the anterior chamber. And once we have a completely opened up scroll, then we will go from behind and then inject an air bubble to help to attach it to the posterior stroma. And that's the end of surgery. And you can also see that we've made a P mark on the cornea to help us identify the correct orientation. So why is DMEK gaining more popularity over DSEK nowadays? And why are more surgeons shifting to DMEK as compared to DSEK? One of the reasons is the fact that DSEK is DMEK is a more anatomically natural surgery. As you can see, there's almost no difference that you can make out pre-op and post-op, because what we remove is what we transplant, unlike DSEK where we tend to add tissue. The other big reason is that DMEK tends to have almost 8 times lesser risk of rejection as compared to DSEK, because you're transplanting less antigenic tissue inside the anterior chamber. And so graft survival after DMEK seems to be much better as compared to DSEK from the perspective of rejection alone. The other advantage is visual quality. Several times when a patient has had DMEK surgery, it is very difficult to even find out that they've had surgery, because the incisions are similar to cataract surgery. And you also have a very high percentage of patients who have 20 by 20, and even patients who have 20 by 16 vision as well. Another interesting aspect is in DSEK, because you transplant tissue that thickens the periphery of the cornea, you tend to have a change in the IOL power of the eye. Whereas in DMEK, you don't have that, and you have very predictable IOL power calculation as well. Visual rehabilitation and recovery is very quick in DMEK. This is a patient with TBK preoperatively. This is day 1 post-op, as you can see, with the half chamber air bubble. And day 3 post-op, the cornea is cleared almost to the level that the patient had before he had any corneal edema. Obviously, this doesn't happen in all cases, but in the large majority, we have very rapid visual recovery in the early post-op period as well. Another important aspect is, like I showed you with the Busen glide in DSEK surgery, you'll need to have an incision size that is at least about 4 to 4.5 millimeters wide. And this induces some refractive astigmatism because of incision alone. Whereas in DMEK surgery, the surgery can be done through incision as small as 2.8 millimeters, just like cataract. So you tend to have a more refractively neutral astigmatism in these cases. So you don't have to worry about inducing astigmatism. And these patients have much more predictable refraction post-operatively as well. So how do the surgical techniques differ? DSEK, we saw that the donor preparation and the availability of the graft was either through manual dissection or through an automated microkeratome. In DMEK nowadays, eye banks in the US have started supplying pre-stripped tissue in glass tubes that you can just insert like an IOL. So it reduces the number of surgical steps, reduces the amount of time the surgeon has to spend as well. The other aspect that I mentioned briefly is like in DSEK surgery, you tend to strip the Descemet's membrane in smaller areas. And in some cases, you don't strip the Descemet's membrane also. Whereas in DMEK, you have to strip the Descemet's for as large an area as possible. And you can see that this should ensure that there is no overlap between the Descemet's membrane that you remove from the host. As you can see, we're removing a very large area of Descemet's membrane, almost 9 millimeters from the host cornea before we insert the graft inside the eye. The other important thing is about the incisions. In incisions in DSEK, we tend to make very long and shelving incisions so that there is no air leakage and the graft tends to seal the incisions from the inside. Whereas in DMEK, this is different again, where the incisions that we make generally are shorter. Reason why this is so is because the DMEK graft is very flimsy and you don't want the graft to go inside the internal ostium or the internal lip of these incisions. So you'll see that the incisions actually are very short, including the primary incision, where we try to keep it a little shorter than even a phaco incision so that you don't have the graft coming into the area where you've made the incision. So marking the graft in DSEK, uniformly, most surgeons don't mark their graft because chances of the graft going upside down are extremely remote in DSEK. This is what we used to do, at least this is what I used to do when I started my DSEK to ensure that I don't lose orientation. Used to mark it with a P, but I don't do that anymore unless my visibility is very poor. And so once you put the graft inside the eye, you can see that the P or the small d that you can see is in the correct orientation. With DMEK, it is more important to mark tissues because if you do not mark, then unless you have an OCT in your microscope, like both Dr. Namrata Sharma as well as Dr. Rajesh Sinha have the advantage of having, you might not be able to see the orientation very well. But once you mark your tissue, you can see very well the P mark that is there in the center that tells you that the tissue is oriented in the correct direction. Loading of the graft in DSEK tissue, like I showed you in one of the previous videos, is usually with the endothelial side up and is very predictable, and you can actually deliver the graft very predictably as well because you can separate the anterior and the posterior lamella and you can very gently insert the graft inside the eye. Whereas in DMEK, the loading is a little less predictable because the tissue tends to scroll up and turn. And so you have to load it using a glass tube. This is a glass tube that we're using to load the graft and then deliver the graft inside the eye. We looked at the different techniques of graft delivery in DSEK. In DMEK, uniformly, the most common method of graft delivery is to use a glass tube. You can use several different makes available in the market. I personally use a DORC or the DORC tube or the tube that is called the Meles tube because it tends to have a edge and it also has a bend, so it reduces chances of tissue being extruded from the eye. Manipulation of the tissue inside the eye, again, DSEK, sometimes once you get your tissue inside the eye, you can go directly inside the anterior chamber and you can see, or I'm holding the graft right now and pulling it in. This is something that you probably should avoid with DSEK. So if I'm not happy with where the graft is, I can go and push it in with my cannula and it will spring back into place because it has great memory, and then you put your air bubble inside. But with DMEK surgery, you are not supposed to directly touch the graft, but only use jets of fluid and allow the graft to open up. And whatever manipulations are done from outside, that is from the surface of the cornea, where you create these fluid currents to help the graft open up. And as you can see, and tapping on both sides to allow the graft to open up. And then once I have one side opened up, I try to move the graft to one edge. And then once that is done, I tend to open up the rest of the graft by these tapping motions once you have complete opening. So you cannot open the graft directly, but you can do it indirectly using these tapping motions. Graft attachment, I spoke to you earlier about how you use an air bubble, whereas in DMEK as well, you use an air bubble, except for the fact that you would want to have as complete an air bubble as possible to ensure that the air tamponades the graft for a very long time and create a PI, because the graft is so thin and it tends to detach much easily as compared to a DSEK graft. So very important to get a complete air fill and also put in air at slightly higher pressures so that the air, or sometimes surgeons use SF6 or C3F8, stays inside the anterior chamber for a longer time as well. So the outcomes with DMEK, like I shared again, seem to be superior to those of DSEK in eyes that have relatively good visibility and eyes in which you have a relatively normal anterior chamber structure. So there are several reasons, like I said, why DMEK is an advantage over DSEK and why you potentially could do DMEK in the majority of patients who require endothelial keratoplasty. But that does not mean that DSEK is a redundant surgery. It still has a major role to play in patients where visibility is quite poor, or where you have comorbidities in the patients, where patients cannot lie flat, or you have extensive peripheral anterior synechiae, or you have a poor posterior graft-host junction, which does not allow easy attachment of your graft, and also where DMEK does not make a difference. Say you have somebody with very poor visual potential, doing a DMEK, like say in a patient who has glaucoma, is not of great value or advantage, because the amount of vision that you will improve for the patient is not going to be very significant. So very briefly, again, want to go through some of the steps of DMEK surgery. So like I showed in the animation, the graft preparation is something I didn't show you, but then again is relatively simple with practice. It is quite easy to prepare and strip a desmase from the cornea. There is a method to it, but obviously we won't go through the entire method. What I'm showing you here is creating a window on the stroma that will help you to mark the graft before you actually take the graft and deliver it inside the eye. So once you load the graft and deliver it inside the eye, as you see in this video, this is a video that is minimally edited to show the key steps of DMEK surgery. Here again, you will see that I'm first starting with air bubble inside the anterior chamber. I specifically chosen a patient who has a light iris so that the maneuvers can be seen more easily. And this case, I'm using an artificial anterior chamber maintainer to remove the desmase membrane if the AC becomes shallow. And once you grip and strip the desmase membrane, it usually comes off in one even membrane. And then after that, you make your incisions. This is my main incision. Then I'm making an inferior side port to make a PI. This is one step in DMEK that is always important to ensure that you don't have to be blocked. And once you've created your graft, you see that this is the window that we have punched earlier. So we're removing the window from the stromal side, then drying the desmase membrane completely. And once you do that, then marking a letter. In this case, I'm using just a Sinskey hook that is dipped in gentian violet and marking the letter P, so that, like I said earlier, again, I can identify the orientation of the graft once it goes inside the anterior chamber. So once I've done that, then we put the window back over the area where the gap was there. And then under fluid, you hold the graft and then you can peel it off the rest of the attachments from the corneal stroma. So like I said, this only needs practice. It does not involve great surgical skill. So like most surgeries, if you have enough practice, you'll do well. Once that is done, then you stain the desmase membrane, and this is with trypan blue, so that you can see the graft when it is transplanted inside the eye. Remove all the trypan blue, and then you see I've loaded this into a glass bowl where I'm trying to get it to open up in the correct orientation. And when I'm happy with the orientation, you see I'm trying to suck it inside a glass tube using just suction. And this is the graft inside the glass tube that you see there. Then removing the fluid so that the glass tube does not allow the graft to move in, reversing it and putting a little more fluid and getting the graft to move to the tip of the tube. Once that is done, then I go in and remove all the air from the anterior chamber. And then if required, using an AC maintainer, especially if you have fibrin or if you have blood, then I'm delivering the graft inside the anterior chamber. Very important that your ACM is only on at minimal flow. And as soon as your graft is delivered, you should switch off your AC maintainer, because you do not want your graft to come outside the eye. Once the graft is completely inside, it generally tends to unscroll. And here what you see is one flange that is towards the top right of the screen has started to unfold. So I'm trying to move the graft to the periphery, hold it down in the area that is started to unfold, and then try to use a carpet unrolling kind of maneuver using fluid currents again to unroll the graft. As you can see, it's starting to unroll. Half of it is unrolled. I can see the P mark is correct. So I'm still holding it down and trying to unroll the rest of the graft as well. And then during these maneuvers, it's also important to center the graft so that it is also having enough place for it to open up. So this is the graft inside the eye. About 2/3 of it is opened up. And I'm only trying to center it so that I have enough space to open the rest. And then I go and just depress the side port, as you can see here, and the rest of the graft opens up quite easily. So that's a very well-centered graft, and you can see the P mark is quite in the correct orientation. So I'm going to be putting an air bubble behind the graft. As you can see, my cannula is turned blue, so it is behind the graft. And one uniform air bubble will ensure that the air bubble at slightly higher pressures. And I typically keep the air bubble in for about 2 hours or so, make the patient lie flat. After 2 hours, you see the patient, and then once you're happy that the air bubble is above the inferior PI, you can send them home. So that is the overall surgical technique between DMEK and DSEK. But also to finish off, to compare how penetrating keratoplasty is being replaced by endothelial keratoplasty because of the several distinct advantages. Well, endothelial keratoplasty, as you've seen, the visual acuity is almost always better because there is no suture-induced astigmatism as compared to penetrating keratoplasty. Similarly, the visual quality is also better, and the recovery is also faster in endothelial keratoplasty. Astigmatism, again, because there are more sutures in PK, you tend to have more unpredictable astigmatism, whereas EK, there is lesser astigmatism, so you tend to have better spectacle corrected as well as uncorrected visual acuity. Chances of traumatic graft dehiscence are possible in PK, but in endothelial keratoplasty, the chances are extremely less because you don't have a graft-host junction. Endothelial cell loss, longer term, is more in penetrating keratoplasty, whereas in endothelial keratoplasty, it's earlier, but it stabilizes about a couple of years after the surgery, and after that, it remains stable for a longer duration. In steroids, you tend to use little lesser steroids in endothelial keratoplasty as compared to PK, which also reduces the risk of steroid-induced complications like glaucoma and cataract. And tissue utilization, you have slightly better tissue utilization because the same tissue that you use for endothelial keratoplasty, you can use for DALK or other lamellar surgical procedures as well. Cost, actually, PK, the eventual cost of maintaining the graft because of the number of visits a patient has to make, as well as the number of transplants that you have to do later because of failed grafts, is more expensive as compared to endothelial keratoplasty, which is less expensive over the long term, and thus it is better than penetrating keratoplasty. Endothelial rejection is also more with PK as compared to EK, and overall EK tends to survive better as compared to penetrating keratoplasty. So in the future, very briefly, what we will potentially see is the use of ROCK inhibitors along with endothelial cell transplants. As of now, there are several groups around the world who have been able to expand endothelial cells in the laboratory, and using these endothelial cells, you can't call them cultures, they're more expansions, and these sheets can be transplanted inside eyes. They've shown the results in primates as well as in patients along with the ROCK inhibitors, and they found very good promise as well from Kinoshita's group. But then we also have found that in some patients, these kind of transplants of endothelial cells along with usage of ROCK inhibitors also seems to provide some early benefit. We still are waiting to see long-term results and also larger patient studies as well. So to summarize about endothelial keratoplasty and where it lies, we went through the evolution of keratoplasty briefly, where India is in the eye banking scenario around the world. And then we also looked at the different techniques of doing endothelial keratoplasty and also the advantages of DMEK and what the future holds. So it seems that endothelial keratoplasty has excellent outcomes in Fuchs and in PBK, as well as in several other disorders like in failed grafts. The better outcomes are in patients who have early edema rather than those who have scarring along with edema, because visual acuity tends to be compromised in these patients. The learning curve is not very long for DSEK, but like I showed you in one of the slides, the with practice, surgeons get better, the outcomes get better even with DSEK. So it's important not just to know the skill, but also to practice and keep doing surgery. Learning curve is a little longer for DMEK, but then again, this is not insurmountable. This is again a surgery that can be practiced and perfected with time as well. And it continues to be a learning experience because there are several scenarios where you learn something from doing EK as well. And it still seems that this is a great teacher and great humbling experience too. But I'd like to end that for the foreseeable future, till we have endothelial cell cultures and transplants that become widely available, DMEK seems to be the future of endothelial keratoplasty, at least in cases that are uncomplicated and have a normal anterior chamber. Whereas patients who have a lot of complications in the anterior chamber, DSEK still is a very relevant surgery even now. So thank you very much for your attention. And that's the end of my presentation. So if you have questions, any more discussions that we'd like to have, we'd be happy to answer.